Hi, everyone. It's Dr. Nasir Ghaemi, and thank you for joining on the podcast this week, which will be on mixed states. And as usual, if you're interested in some of this material, please go to our website, psychiatryletter.com. We'll put a link in the comments section where you can read about more material, download resources, sign up for webinars, and be in the know as we're preparing new material for everybody. So go to the website again, psychiatryletter.com, if you're interested in further follow-up on these ideas. And I have my friend and colleague, Daniel Herringer, who's a resident at Cleveland Clinic with me here today to continue the discussion on this topic. Hi, Daniel. Thanks for joining.
Hi, everyone. I'm happy to be here. Happy to participate in the discussion later.
Great. Thanks, Dan. So we're going to start with a little commentary and topic presentation, and then Daniel will come in for the discussion. And feel free to put comments in the chat for those of you who are here on the live stream, and we will follow the comments and answer questions and so on. So the topic today is mixed states. Mixed states is when you have depressive and manic symptoms at the same time. And one of the interesting things about the concept of mixed states is it's very underappreciated in contemporary psychiatry, partly because of the DSM system's distinction between bipolar illness and so-called major depressive disorder, or what partly used to be called unipolar depression. We'll use the phrases bipolar, unipolar for now, although it's not exactly the same thing as so-called major depressive disorder, or MDD. But in 1980, with the third edition of DSM, DSM-3, this distinction was made between bipolar and unipolar depression, or MDD. And the idea was that you had to identify patients as being either depressed or manic, and that's how you make those two diagnoses, as people know. The concept of mixed states was basically ignored and was defined, if at all, very narrowly to mean having full depressive and manic episodes at the same time, which basically doesn't happen. So the concept was ignored. It had to be essentially legislated away, because if mixed states occur and if they're common, then the whole distinction between bipolar illness and unipolar depression becomes more problematic. You can't differentiate bipolar and unipolar because you can't differentiate depression and mania, because most people are mixed. And in fact, many clinicians don't know, although those who read the Psychiatry Letter and follow our podcast will know, that the old concept of manic depressive illness meant having depressive or manic episodes. It didn't matter whether it was just depressed or manic. It could be either one. Manic depressive illness essentially meant bipolar illness plus unipolar depression. It meant that there's no distinction to be made at the diagnosis level. Yes, the symptoms may differ, but that doesn't make it a different diagnosis or a different disease. In contrast with DSM-3, the claim was made that these were different diagnoses and different diseases. By, as we've discussed, claims about validity, research on genetics and course of illness differentiating the two conditions. At that time, as we now know with 40 years more research, the genetics and course of illness do not differentiate bipolar, unipolar, and essentially supports the old concept of manic depressive illness, that these are represent one illness. I think that the reason that Kreplin held the view that manic depressive illness is just one illness was because most episodes were mixed. There was no point in trying to distinguish between depression and mania, because most people didn't have depression or mania. Most people were mixed. Most people had both symptoms at the same time. So manic depressive illness means not just depressive or manic episodes, it also means mixed episodes most of the time. Most episodes are mixed. I'm not going to show you the research, but there are studies that show that when you look at mood episodes in general, and you look at mixed states the way we're going to define them, about 60% of mood episodes are mixed, 60. Only about 20% are pure depressive episodes, and only about 20% are pure manic episode. And this is in unipolar depression and bipolar illness, not just bipolar. Mixed states, common misconception, people think it's part of bipolar. No, it's part of unipolar as well, because there is no distinction to be made between bipolar and unipolar if mixed states are common. and that was the view of Kreplin regarding manic depressive illness. So the concept of mixed states is really centrally important from a diagnostic perspective, as we've just gone over. It's also important from a treatment perspective. Again, we're not going to have time today to show you this research. We go over all these data in detail in our webinars on psychopharmacology, but there are studies that show that mixed states respond to dopamine blockers, so-called antipsychotics, and probably respond to lithium and anticonvulsant mood stabilizers, but they do not respond to so-called antidepressants. And in fact, antidepressants make mixed states worse. They make patients more mixed, more depressed, more agitated, and often suicidal. So it is a major problem that patients are getting diagnosed with so-called major depressive disorder, MDD, even though they have mixed states. The mixed concept is being ignored. They're just being labeled depressed. They get so-called antidepressants like serotonin reuptake inhibitors. They get more mixed, which is misinterpreted as just worse depression. They then get more antidepressants, or a second one, get labeled treatment refractory depression, and go down that rabbit hole, which ends in ketamine and psychedelics, making people no better than they were before, and complete failure of the treatments. And in fact, what's being missed is that they have mixed states. They don't have quote unquote depression or treatment resistant depression. And what they really need is a dopamine blocker or a mood stabilizer. Now, sometimes the patients will get dopamine blockers or even mood stabilizers added to the antidepressant, but that doesn't work because the so-called antidepressant is worsening the mixed state and counteracting the benefit of the dopamine blocker or the mood stabilizer. The antidepressant has to be stopped. If you don't stop the so-called antidepressant, the patient will not get better when they have mixed states. Then they do respond to dopamine blockers and mood stabilizers. You might be wondering, well, there's FDA approval for dopamine blockers added to SRIs for depression. Yes, and that's because the FDA won't, it basically requires the patients with so-called MDD to be on the standard of care, which is SRIs, serotonin reuptake inhibitors. And so the antipsychotic has to be added to the SRI. It's not because they've done research that shows that the antipsychotic doesn't work by itself and you have to add it. That's actually not true. The FDA doesn't allow that research for ethical reasons, for marketing at least, and companies have to add the antipsychotic to the SRI. However, there are studies that are done outside of that setting with unipolar depression, especially in mixed states, that do show that antipsychotics or dopamine blockers are effective in mixed states by themselves, not added to SRIs. So you don't need the SRI. In fact, the SRI is part of the problem, in my view. And the so-called antidepressant needs to be stopped, and then the antipsychotic or dopamine blocker can be used for the mixed state, along with often a mood stabilizer is a good idea as a long-term, for long-term prevention. But also sometimes helps for short-term symptoms. So that's my general view of mixed states, that they're common and that they are very important diagnostically and therapeutically. Diagnostically, because in a way, they disprove the DSM system, and therapeutically, because the treatment is so much worse with the most commonly given agents, the antidepressants, and we can really make patients with different classes used instead, like the dopamine blockers and mood stabilizers. So before I bring Daniel in, I just want to show you a picture of what I mean by all this. Here you see a pyramid that gives an idea of different concepts of mixed states. On the top, we have the DSM definitions. DSM-4 was very narrow. DSM-5, as you know, added mixed features to MDD, major depressive disorder. But it defined mixed features conceptually, not based on any research or any empirical data. It defined mixed features as being the symptoms of mania that do not, quote unquote, overlap with depression. So it excluded distractibility and irritability and psychomotor agitation. And it requires then person to be depressed and euphoric at the same time, which of course doesn't happen. But also then to have grandiosity and flight of ideas, decreased need for sleep. But they're not, if they're agitated, which is commonly the case, or if they're irritable, that doesn't count as a feature that can be used for the mixed state. To me, that doesn't make sense. It's like saying, hey, I want you to diagnose migraine, but don't use headache as a symptom, because it doesn't, it overlaps with other kinds of headaches, other kinds of non-migraine headache. To me, that's not rational. And there was no scientific rationale for that DSM-5 decision, but that's the way they made it. So it is a narrow definition of mixed states. The broader definitions that have more evidence for them include the bipolarity specifier, angst, which is basically having manic symptoms for less than 4 days, meeting the full-blown hypomania mania criteria, but less than 4 days, which is the hypomania cutoff, again, for which there's zero scientific evidence for the 4-day definition. Or a broader definition by Koukopoulos, mixed depression, which we'll go over soon, which essentially means having a lot of anger, rage, and agitation along with the depression. And we should mention that Akiskel made the point that the reason that people have mixed states so much is because they have underlying mood temperaments like cyclothymia and hyperthymia, so that they're a little manic all the time anyway. And when they get depressed, the depression mixes with that baseline hyperthymia or cyclothymia and produces this mixed state. So that's an even broader definition. But to kind of spell out what this means, the DSM definition is non-overlapping manic symptoms for which there's no scientific evidence. There is scientific evidence for either the bipolarity specifier, which means meeting hypomanic episode definitions for less than 4 days, or Koukopoulos' mixed depression, which means having a depression along with psychomotor excitation, which usually reflects agitation and anger, as I'll show you here. So here's the official criteria that Koukopoulos published. You have a full-blown depressive episode. That's, you can use standard DSM criteria for that. And then you have multiple other psychomotor excitation criteria. As you can see here, mood lability, marked irritability or anger, psychomotor agitation, flight of ideas, increased libido, impulsivity, could be sexual, could be otherwise, and so on. The big picture here is someone is excited, agitated. They're not slowed down and psychomotor retarded. The psychomotor retardation reflects melancholia, which is the opposite of mixed states. The psychomotor excitation reflects mixed states. So this is really your angry, agitated, depressed patient. That's not the same disease as your melancholic patient who's laying on the bed and not only is not angry, but has almost no feelings at all. So this is what we mean by mixed states. Again, to go back to the pyramid slide, I think of mixed states in these middle definitions. The bipolarity specifier, meaning brief manic symptoms, multiple symptoms lasting a few days, 2 days, 1 day, even a couple hours. Or mixed depression by Koukopoulos' term, which is maybe weeks or longer of depression, but with a lot of anger and psychomotor excitation. If you define mixed states this way, you're talking about 50 to 60% of all mood episodes. You're referring to the majority of patients with both unipolar depression and bipolar illness, and you're essentially defining away all these patients that get labeled major depressive episode and get SRIs and other antidepressants, and for which they do not get better and often get worse. And we're able to then instead treat these apparently depressed patients with dopamine blockers and mood stabilizers, because we realize it's not pure depression, but rather mixed depression or mixed states. So that's my summary, and let me invite Daniel to come on. Let me get this off the stage here. Sorry. Okay, and let's have Daniel come on here and tell me what you think, Daniel. Thoughts, questions, ideas.
Well, I really like this topic because it shines light on just the phenomena that we actually see in practice when we're seeing the patients. And it really brings a little bit more clarity to that. Before I keep going, I'd encourage everyone that's watching to send your comments and questions to the comment section here. We would love to take a look at them, and Dr. Ghaemi would answer those in a few minutes. So, Nasir, what I wanted to do and explore, use this time, exploit a little bit of your mind in terms of descriptions of different types of presentations that we see, and clarifying if it's actually mixed depression, or is it actually mixed features. So the first one that comes to my mind is the presentation of the patient that comes with suicidal ideation to acute inpatient units. And their presentation is marked by racing thoughts, excessive concerns. They're like all over the place. And there's clearly a lot of internal psychic energy.
Right.
So they just end up with a couple of diagnoses, right? They just end up with the MDD-GAD combo. But to me, it's actually a quite different presentation than the melancholic patient that has a very severe, slow way of thinking, slow way of talking. And I wonder, what's your view on that? Do you think that kind of anxious depression is also a mixed state?
Well, see, I think the term anxious depression is unfortunate. Anxiety is almost a useless concept in my view. It's the most non-specific symptom in psychiatry. It's the fever of psychiatry. It's what you can get with all kinds of things. If you're depressed, you can be anxious. Manic, you're anxious. Psychotic and schizophrenia, you can be anxious. OCD, you're anxious. PTSD, you're anxious. Anxiety is useless. It's there all the time. By itself, it doesn't mean anything. You can also have anxiety as a personality trait and have it by itself. That's neuroticism. So it can be had by itself, but outside of neuroticism, it's usually a secondary feature of a lot of different forms of psychopathology. And so in mixed states, also, patients are anxious. So in my view, there's no such thing as anxious depression. You either have mixed states where you have anxiety and agitation along with the depression, or you could have other kinds of depressive states where there's some anxiety, like neurotic depression, for instance. And neurotic depression just doesn't mean you're only anxious. It also means it's chronic, mild, it's non-episodic, and it's non-genetic. You have to look at the course of the illness and the genetics, not just the symptoms. So just telling me about someone's symptoms, they're anxious and they're depressed, doesn't tell me much of anything. I want to know the course of illness and the genetics, and then I can tell if they have neurotic depression or mixed states. And with mixed states, you also will have some other features. Now, the psychic anxiety, and Koukopoulos called it psychic agitation. That is part of mixed states. Usually there's a motor component, so there's psychomotor agitation. Sometimes there's not as much of a motor component, it's more psychic. But if the patient's having rapid thoughts and these thoughts are labile and they're at all impulsive in their thinking, say, that's a mixed state. If they're not having impulsive labile thoughts, they're just worrying about things. It might be rapid, it might not be, but especially if it's not rapid, just worrying about things in a non-rapid way is not a mixed state. That's just anxiety, which again is non-specific. And then you can look for other aspects to the illness, the genetics, course of illness, to try to figure out what that is.
Perfect. So we're differentiating here the whatever changes during the acute mood episode with the baseline. And this is an interesting concept as well. And I wonder if you could tell us a little bit more about those kinds of patients with a little bit of a higher energy baseline. Even Dennis brought a question here, and I think I'm going to tie it up a little bit with what I'm saying. In patients who have like a chronic unipolar mania, so to speak, like a chronic baseline, high energy, hyperthymic temperament, for example, during their depressive episodes, how different does it show in terms of presentation when they go acutely to our units or to our offices?
Yeah, I mean, I think that was Akiskel's idea. Akiskel's view is that these mixed states that we're talking about are preceded by hyperthymic temperament or cyclothymic temperament most of the time. So if you look for it, you'll find that these patients also have that. And I think that's a reasonable idea. It's not so much a difference in description of the mixed state. The mixed state is, what Koukopoulos says or Angst says, but it's more of a description of why they're mixed. The reason they're mixed is because they have these mood temperaments. That's Akiskel's idea. Let me just answer Dennis's question too. Is there such a thing as unipolar mania? Yes, unipolar mania is episodic, though. So you might have a manic episode for 6 months, nothing for 6 years, another one for 6 months. That's unipolar manic illness. There is no such thing as chronic unipolar mania, meaning you're manic for 6 years. That doesn't happen. But that is, I think what you mean by that is hyperthymia. That's what we're talking about. Manic symptoms all the time. That could be for 60 years nonstop, your whole life. It's just that it's lower level than a full-blown manic episode. So that'd be my answer to that question. Daniel, did I answer the question enough about the interaction between temperament and mixed states?
I think so, but I think we could still explore that topic. Larry also brought this this up, and I think there's a lot to kind of like pinpoint the differences on what's actually episodic. So what's the difference between a pure mixed state without a mood temperament, for example, versus someone who has at baseline chronically easily gets angry, easily gets up and down, easily gets mood swings, versus when they're acutely in a mood episode.
Well, no, the difference is when you have a mixed state, you're in a full depressive episode. A full-blown clinical depressive episode. You meet 7 out of 8 criteria for 6 months of clinical depression. That's not a personality. That's an episode of severe depression. Nobody's like that for 50 years. They can be like that for 5 months, maybe. So, Larry, I think it's not true that mixed states are not mixed symptoms are non-specific, like anxiety, agitation, anger. That's not part of your personality, because in mixed, maybe we should use the phrase mixed depression to bring the point home. You're in a clinical depressive episode, full blown. That's not a personality state. It's an episode. It has a beginning and an end, usually lasts 3 to 6 months. If that's not what you're having, then it's not a mixed state.
What about those cases that our patients describe that most of the time at their baseline, they have ups and downs, very extreme. They get on top of the world, but they are triggered, and then soon they change and they're super sad. And that's a recurring thing. And we do see that in the office, and patients do describe it like that. And it often gets, I wouldn't say dismissed, but understood as part of like cluster B personality traits, for example. Right. But I often wonder how much of that is, well, mixed features of depression.
No, I mean, it's not neither one. You've just described cyclothymia very well. That's what cyclothymia is. So when we're saying their baseline personality is cyclothymic, that's that. Then they go into a severe depressive episode for 6 months, along with excitation, agitation. That's a mixed state. Then they go back into their baseline personality that you just described. That's cyclothymia. There's zero evidence that that mood lability is definable as borderline personality disorder, or so-called cluster B. Borderline personality is not, validity evidence is not there that these mood symptoms differentiate it from other conditions. Other things may differentiate it, like self-cutting and sexual trauma, but not mood lability. So that's cyclothymia.
I think I might have a.
Yeah.
I think I don't have a complete understanding of the cyclothymia. I had the impression that cyclothymia would be mild depressive, mild manic symptoms, like over the course of several weeks or months, instead of like
no.
Patients would describe the same day triggered from top of the world to feeling super sad.
Not at all over weeks or months. That's not cyclothymia. That's rapid cycling, because you're having full-blown mood episodes that are lasting 2 weeks or longer. Cyclothymia is on the order of hours or days.
Gotcha. So that's okay. So that would be the mood temperament, and it's based on what we just discussed.
We should do a separate podcast on what mood temperaments are again, to really describe them clinically.
Maybe, that could be a good idea too.
Yeah.
Dive deeper on that cyclothymia, because it's often difficult to bridge together all those concepts with what we actually see in practice, and oftentimes what we're taught is different from practice and closer to what you have been telling us here on these podcasts.
Yeah, I mean, I for myself don't have a problem what I see in practice is what I'm describing. But I think that some of these terms, even though they actually are old ideas, cyclothymia and mixed states are 100 years old. We have become so ignorant in the last 40 years after DSM-3 that these are all new ideas for clinicians now. And so it's hard for people to really understand what they mean. The way I'm defining it is not something I'm making up. I'm defining the way these things have been described for over 100 years.
This question is interesting. I don't think I can pronounce the name of the user that brought it up.
Okay.
But
that's Thomas. He said his name is Thomas.
Okay.
Yeah. But he says in the Kiskel's concept, bipolar 2.5 is defined as depression superimposed on a cyclothymic temperament, which comes very close to borderline personality disorder. How to differentiate? No, it's not the same. I keep telling people, it's unfortunate, I have to say, that people think that borderline personality has to do with mood lability. It doesn't. That's in the DSM definitions, but it has zero scientific evidence for it. Borderline personality, as it was defined in the 60s and 70s by Kernberg and Gunderson before DSM-3, meant you have sexual trauma in childhood, then you cut yourself repeatedly, and you're a very angry person. That has nothing to do with having mood swings on the order of hours. And if you do have mood swings on the order of hours, that's not specific to borderline personality. Why are we allowing that to be a borderline concept, but we won't let psychomotor agitation or irritability be a mixed feature? It overlaps with a million other diagnoses, obviously, and especially in mood illnesses. It's not specific to borderline personality. So it's totally irrelevant. You don't need to differentiate it based on mood lability. You don't differentiate migraine versus non-migraine headaches based on how the pain in the head is, how bad is the pain in the head. You differentiate it on specific symptoms, other features of the headaches. So you should go to other features of borderline personality that differentiate from bipolar illness. And what differentiates, again, going back to the 4 diagnostic validators, is not these symptoms. It's genetics, course of illness, and sometimes treatment effects, but mostly genetics and course of illness. So bipolar patient has bipolar genetics, borderline patient does not. And the course of illness for borderline personality is childhood sexual trauma and repetitive self-cutting. Bipolar is not. That's how you differentiate.
But Larry also brought another question, still on the differentiation of mood temperaments and mixed states.
Yeah, so do you consider someone who has hyperthymic temperament who also currently is in a depressive episode to be in a mixed state? They are if they have the mixed features that we talked about. You just have to apply the definitions I went over by angst, which means having manic symptoms lasting either hours or days, or Koukopoulos, the depression with psychomotor excitation. So it's not a matter of saying just because they're hyperthymic, they're in a mixed state. It's rather defining the mixed state and then noticing that they also have hyperthymic temperament beforehand.
Do you often find it's more common on patients with hyperthymic temperament to have mixed states?
That's what a Kiskel said. I haven't seen research on it to be able to say so, based on numbers. But that's my clinical experience as well, yes.
What about more mild depressive episodes in patients who have a hyperthymic temperament? Since we're talking about this now, I know it's a little bit away from exactly mixed features or mixed states, but I wonder if the cutoff for a depressive episode in a patient with a hyperthymic temperament who's having a mild depressive episode, it's more common to have more mild depressive episodes that wouldn't make the cut for a full-blown depression.
Well, a mixed state is, again, mixed depression may be the right phrase. Depression is depression. So if it's not a full-blown depression, then it's not a depression. So if you're saying depressive symptoms lasting less than a few weeks that are not severe enough to meet full depression criteria, yeah, you could have that, just like you can have a pneumonia and have it be mild enough that you don't have a lot of symptoms and you don't end up in the hospital. Sure. I mean, you can have depressive states that are mild, moderate, mixed, severe, meeting full episode criteria, being less than an episode, just like you would if you weren't hyperthymic. I don't think the mood temperament influences that any. We do have
Fair
one
enough.
question here, Daniel, from Larry. I'm sorry, okay, we got another one from Larry. It's okay. I was thinking we can read that one, but there's another one here I wanted to get to.
Okay.
So Larry says, people who score high on the temps for hyperthymia and they go into a depressive episode do poorly on SRIs. Yeah, that's because they're mixed, probably. That would be my opinion. Lamotrigine seems to work better. It might. This actually relates to the other question we had gotten from Thomas, where he says, in regards to treatment response, there's a non-response of lithium in mixed states. Would you favor valproate or lamotrigine? So actually, this is another common, somewhat misconception. It's true that there's not less response with lithium in mixed mania. That's what's been shown compared to valproate, but not mixed depression. And that's an important distinction. There aren't studies of mixed depression with lithium and valproate and so on. This is a newer, actually, it's an old concept, like I said, but it really hasn't been discussed much in modern psychiatry until the last 10, 20 years. So you're thinking about studies from the 90s, which showed that valproate was effective in mixed mania more than lithium, but it hasn't been studied in mixed depression, none of these definitions that we gave. So I don't think one can extrapolate from the mania studies to the depression ones. And in my clinical experience, lithium works perfectly fine in mixed depression. So I don't think there's any special reason to not use it. In fact, I would highly recommend it as the number one choice, as I do for almost every possibility for lithium. That doesn't mean valproate wouldn't work, or maybe lamotrigine. It's interesting to me that Larry found that lamotrigine works. It may well, because mixed depression is a different category of patient than pure depression or pure mania. But lamotrigine was shown to be ineffective in pure mania in the acute studies. And it was shown to be ineffective in bipolar depression, which of course includes both mixed and pure patients. So I'm skeptical about lamotrigine. Other colleagues of mine, though, who treat mood temperaments often use it. I've had a few patients do well with it too. I could be wrong in my skepticism, but my skepticism comes from the idea that if a drug is not effective for mania, it's probably not going to be effective for mixed states, because mixed states involve manic symptoms along with depression. And lamotrigine, though, might be an exception to that rule.
What was the question that you were thinking of answering? It was this
That was
one?
the one. That was
Okay.
this one that's on the screen right now. Yeah.
I think Thomas also made another comment on lithium levels, I think.
Yeah. So I think you can be levels, in my opinion, are completely unimportant for lithium. I'm going to just completely put it out there as a complete contrast to everything that we've ever been taught, including what I used to teach and do and practice. I've come to the conclusion in recent years that levels are completely irrelevant. The only reason to check a lithium level is for toxicity. It's not for efficacy. You want to check it to make sure it's not 1.5 or 2.0. It doesn't matter if it's 0.8, 0.6, 0.4, 0.2. At those levels, what matters is the clinical efficacy. So just give the lithium I start at 300 milligrams. I go really low. I go to 450. I wait a long time. I go to 600. I keep waiting until the patient gets better. If the patient gets better at those lower doses, I leave them at that. And then I'll just check a level just to document it to make sure it's not 1.8. If I don't get a response at these low doses, I'll go to 750. I'll go to 900. I'll check a level to see if it's 0.6 to 0.8 if they're not responding. But if they respond, again, it doesn't really matter. So the simple answer is dose to clinical effect, not to the level. And there isn't good research on mixed depression because people are ignoring the concept. But my hunch is that if we did have the studies with lithium and mixed depression, we would find that patients would respond at lower levels than has traditionally been used. But I think that's the case actually in all patients. I think in bipolar type 1, type 2, and mood temperaments, lithium works in a lot of patients at low levels. And we mistakenly go too high on the dose because we've been mistakenly focused on the idea that you have to get a level of 0.6 or 0.8, which is actually not proven. There aren't good studies that show that if you have a level of 0.6, 0.8, you have more efficacy than lower levels for bipolar depression, for instance. There's no research at all that shows that. Or even for mania, there's some research for acute mania. And there's a little bit of research for maintenance prophylaxis, but not much. And it depends on the subtype of bipolar illness as well. So I would encourage you to be liberal with your levels, check it, but don't worry about it too much. And again, dose to clinical effect.
Oh, awesome. We discussed so much today. I think this is a very rich and very complex topic, a lot to learn. And I really want to thank everybody that was with us, that spent some time with us. Larry, Thomas, thank you so much for sending the questions and the comments. Dennis, thank you so much. We really appreciate your participation. And we wanted to invite you. I'll let Nasir make the invitation for what we're starting next week.
Yeah, well, I'll give my description, and Daniel, you can add or subtract. But we're planning on having 3 sessions where we're going to give a sneak peek at the first couple chapters of the 2nd edition of Clinical Psychopharmacology, my textbook, where I'm going to go over what I'm putting into the first few chapters, which have to do with psychopharmacology, mechanisms, psychopharmacokinetics, things like that, some neurobiology relevant to psychopharm. And we're inviting people to join us for those couple sessions, and that will be a sneak peek of what we're planning to write. And Daniel, I'll let you describe anything further about it that we need to say.
I think that's it. I would invite you, if you're watching us, to click the link in the description, give your email so you can be notified. We're starting next week. It's going to be the same time as you're already used to, at 4 p.m. Next week, Dr. Ghaemi will bring deeper dive, deeper lectures with complete slides, going over a few of the chapters of the new book that he's writing, the new edition of his psychopharmacology book, where he goes over his complete view of psychiatry. And the first few chapters are on the fundamentals of psychopharmacology. Very interesting views, very unique. And I would love to have you all there. I'd love to have you join us to the lectures and participate in the discussions later. It's going to be exclusive. It's not going to be for free on YouTube. And if you do want to participate, make sure to click the link, and we would love to have you there. This is going to be the most inexpensive product Dr. Ghaemi is going to make, and it would be a great opportunity. If you do want to participate in that, I'd encourage you to join us on this 3-part masterclass series on the fundamentals of psychopharmacology.
All right, great. Thank you, Daniel.
All right. Bye-bye, everyone. It was great having you all with us, and I hope to see you all next week. Bye-bye.
Thank you all.